In the last section, we talked about peripheral pathways, and peripheral pathways are basically taking information, whether it's sensory information like pain or non-painful sensations or other sensory information. It's taking it from the periphery to the spinal cord. The central pathways are taking information from the spinal cord to the central nervous system. And those central pathways, the peripheral fibers project to the dorsal horn of the spinal cord, and that's gray matter. And gray matter is always the cell bodies. The spinal cord connects either directly to the ascending system or via interneurons. So interneurons are shorter neurons that go shorter distances, and usually the communication within the spinal cord and within the cerebral cortex is accomplished by interneurons. Interneurons are subject to what we call pain gating, and physical agents are mostly thought to control pain in this manner through gating. So the idea is, if you can send a sort of an interrupting signal or a canceling out signal into the dorsal horn of the spinal cord, you can stop the pain from ascending into the central nervous system. Pretty cool, right? And we'll talk about the different agents and how they do that when we get to each individual one. So with spinal cord modulation, it's the gate control theory is what it's called. And we'll talk more and more about this in neuro next quarter. But the severity of the pain is determined by the balance of excitatory and inhibitory inputs in the spinal cord. So the A delta and C fibers are going to be excitatory inputs. The A beta fibers are going to provide inhibitory inputs. And if there's enough inhibitory input, you can actually close the gate, is what we call it, in the spinal cord and keep the pain signals from going up to the central nervous system. So we call this, it's altering pain transmission. So it's not altering the pain input, it's not altering anything in the central nervous system, it's actually altering the transmission of pain. So you get to the dorsal horn of the spinal cord and it says, I don't think so, you're not going to send it past here. So we close the gate. So that is an ascending pain control or pain modulation system. So we stop the pain from going up to the central nervous system. The endogenous opioid system is a descending system. So endorphins that are produced by the brain control pain by binding to opioid receptors. So the brain produces its own chemicals, and it descends to control the pain from that end. So there are other anti-nociception or pain control, pain modulation systems in the body. There are also pro-nociception pain elevation systems in the body, and we will talk more of those next quarter. But basically what we're going to talk about in this class is spinal cord modulation via gate control theory as ascending pain control, and endogenous opioids as descending pain control. So a lot of the physical agents that we use spinal cord modulation to control pain. There are a couple of them that we're going to talk about that actually activate the endogenous opioid system. So we'll talk about that, and we'll also talk about how we figured that out, because how do you figure that out? So with gate control theory, we want to basically create conditions that open the gate. So the physical conditions we don't want to create conditions that open the gate. If the gate's open, we can transmit pain. So physical conditions that open the gate and allow the transmission of pain include the extent of injury or inappropriate activity level. So if you have a really big injury, you're not going to be able to have enough counter irritant from the A beta system to damp that down. If you're like walking on a broken leg, that's inappropriate activity level. So that's a physical condition that can keep the gate open. Emotional conditions that can keep the gate open are anxiety or worry, tension, like muscle tension, anxiety, psychological tension, and depression. So if we can alleviate some anxiety or worry for our patients, that can help close the gate. Mental conditions such as focusing on the pain or just plain old boredom, which, boredom can keep the gate open. So a lot of times people will report after surgery that they have so much more pain at night. And there are a lot of reasons for that, some of which we'll go into later. But one of the reasons is that at night, there's nothing else to distract you. And so you just have to lay there and be in pain. And focusing on the pain doesn't help either. So sometimes you can distract people out of pain. So distractibility is a good thing. Sometimes it's a way of assessing pain. If they're not distractible, they're sort of at a higher level of pain. So conditions that close the gate, physical conditions can include medications and counter stimulation, such as heat or massage. Or electrical stim. Some types of electrical stim can provide counter stimulation. Emotional conditions that close the gate include positive emotions, relaxation, rest, petting puppies, listening to music, involvement and interest in life activities is one of the mental conditions. Intense concentration or distraction is another one. Sometimes when we're doing relatively painful procedures in physical therapy, I often I'll tell my patient, close your eyes, take some nice deep breaths for that relaxation response. And imagine that you're on the beach in Hawaii and there's a beautiful breeze blowing and a nice little guided meditation can help distract them from the pain. And involvement and interest in life activities, if you're bored and you have nothing to do but feel pain, you're going to feel more pain. If you've got stuff going on and you've got people supporting you and good things to read and whatever, then you're going to feel less pain. Those are conditions that close the gate. So with central sensitization, so we talked about peripheral sensitization. Central sensitization comes from the brain or the central nervous system, and it facilitates nociceptive impulses. So it amplifies pain, basically. So there are three aspects of it. Facilitation of synaptic transmission in the spinal cord, because that keeps the gate open. Inhibition of endogenous opioids, that keeps the descending pain control system from working, or altered processing of nociception in the brain. So that's considered neuropathic. There's been a change in the nervous system that is changing the way we process pain. So that can be a real problem. That can be the cause of a lot of chronic pain syndromes. Central sensitization can cause pain that does not fit in a typical anatomical or neurological distribution because the brain is creating the pain itself. Interesting, right? So in the next section, we're going to talk about pain modulation and control and how are we going to do it.